is an honor and certainly a privilege to have assumed the role of chair of the Ivey International Center for Health Innovation and Leadership. I must tell you, it has been an extraordinary 6 months since I took on that role. And one of the privileges associated with that role is I've had the opportunity to travel across the country and globally and spend a lot of time talking with very interesting ideas and perspectives around health systems, both within our country and globally. And there are patterns that emerge. I'm a qualitative researcher by training, so I'm always hearing and these patterns jump out at me. And one of the most consistent, and first and foremost, is that Canada is a much loved country. It is really one of the countries in the world, no matter where you go, you are embraced, and the feedback you get is what a wonderful country and what a wonderful healthcare system. Everyone has opportunities to access healthcare when they need it, and I don't disagree. But I'm also a researcher, and I always go home and think, yes, it's a wonderful healthcare system, but two things, thank you. Is it sustainable? Going forward, are we always going to, as Canadians, going to be able to rely on the strength of that healthcare system? And given that we all grow older, none of us can escape that, will it be there when we're older and need it dramatically and when our children need it? So one of the questions we asked was, how is our healthcare system relative to the other countries around the globe that we're often compared with? And there are many reports that come out from OECD, the Commonwealth Fund report, that will actually position health center performance. And as it turns out, we're struggling with some substantive issues in our healthcare system, as are many other countries. The question is, how are we doing relative to our comparator countries? And are there things that we can learn? Again, being an academic, you're always looking for not only what's the evidence, but what's the opportunity for learning. So that's really the basis and the framework with which we approach this white paper on what are some of the ways health systems have found to use innovation to strengthen them so that they become sustainable, and those health systems will be there when each of us and our families really need them to be there. So let me share with you what we found and some of the interesting trends and patterns that are emerging from our comparator countries. Clearly, when we look at Canada's performance to date, our health systems are expensive. And systems meaning that they're delivered, of course, by each of our provinces and territories. Depending on who you speak to, they're consuming upwards of 50% of tax revenues in each jurisdiction. The question again comes back to me, is that a sustainable price tag for this wonderful healthcare system? More importantly, those costs are outdistancing our gross domestic product as a country, so that makes it a little bit more urgent to really question in the future, will this system be sustainable and will it be there for people who need them? Health system costs per capita are among the highest among our OECD country comparators in Canada, and I'll show you that data just very shortly. At the same time, we're still struggling with wait times. Wait times are problematic. The longer people wait, the greater the chance that risks increase and the outcomes for their health outcomes overall become at greater risk. Chronic illness rates are increasing, and as a pediatric nurse, the one that really worries me is the current generation of Canadian children in this country is the first generation in our history that may not outlive its parents because of the rates of childhood obesity, which are the precursor to many chronic illnesses. So that one is a worrisome one. And finally, when we look at our health quality relative to the money we're putting into our health system, our rankings look quite low. So just a couple of quick slides. One person asked me, well, is that because our population's aging or because we have a vast geography? Well, in this slide, it shows you that, see that blue line at the top? That's actually Germany. They're the oldest population among the OECD countries we're often compared to. Canada's actually in the orange circles. We're at the bottom. So relative to our other comparator countries, we're actually quite young. So that's not an explanation for why we seem to need to spend as much as we do per capita on our health system and reaching quality outcomes that are not comparable. Here's the other piece. Wait times. I'm always reading about wait times in newspapers. So have a look at the very dark pumpkin-colored bars. When you look across, that's the 2010 data. This is coming out of the OECD report released last week. If you scan your eye across those darkest orange bars, we still have the longest wait times among all of those comparator countries. But what really jumps out at me on this slide is the size of our wait time relative to that of France, Switzerland, Netherlands, and Germany, which is less than a third of what ours is. So I think there's much more we can learn from those particular countries. Without a doubt, though, there is no single country you can look to as the gold standard, the benchmark that everyone needs to chase and achieve, because no country has completely figured out the answer as to how do we create a highly productive, efficient healthcare system that's cost-effective, sustainable in the long haul, and able to manage and provide the quality care outcomes for the population who need them. They all struggle with this aging population dynamic, where populations are aging, life expectancy, because of our wonderful research and technology, is increasing at the same time. And again, chronic illness plays a major role. Many of the health systems struggle with balancing the costs while maintaining the quality. And the third one we hear a great deal about is the fragmentation in health systems. Generally, health systems in the developed world were developed on a 1950s model where acute care was the most urgent need for health services. But now we have populations which are older with chronic illness needs that are really not well managed in acute care models. So we get this very interesting and very challenging fragmentation. Quick slide on how we visually compare ourselves to other countries. That solid blue line just above the black one is Canada. The only country that spends a higher expenditure and share of their GDP is actually our neighbors to the south. Hence my suggestion that even though they are our neighbors and we do share a border, that might not be the comparator country we need to spend a lot of time looking at. In terms of the money we're spending and the return on that investment, that ROI, as a business school would normally like to look at, we looked at the data on the health consumer ranking. How healthy do consumers see themselves in each of these countries? And we plotted it in a regression model against how much money we're spending as a health system. Canada, again, is very, very low on consumer health index relative to every one of the other countries that we're actually comparing and looking at in this analysis. So again, more evidence that we have much to learn from our comparative countries, and it is worth noting US was not, we did not have the data for US in this particular analysis, and nor did we have it for Australia. So what comparator countries did we select then to learn from? United Kingdom, no question, every time I hear and talk about health innovation, United Kingdom comes up in that conversation, and for very good reason. Australia, a country that boasts the highest, longest life expectancies in the world, and they still navigate very large land masses as Canada does. Germany, one of the oldest countries in the world in terms of population, but a benchmark for safety and quality. Similarly, Netherlands. France, last time WHO ranked health systems, France was ranked as one of the most impressive health systems in the world because of its open and 100% access to health services. Switzerland, not particularly viewed as innovative in many of the data and many of the publications. However, its population see it have high rankings on satisfaction with their health system. So again, something to learn more about. And the United States, you can't leave the US out. They're just too important a country, and what are some of the lessons we can learn from the United States? And of course, cost and the spending per capita may not be one of them, but there are many, many others. So how did we go about this analysis? Really, we looked at four things. The governance structure, in other words, the context in which these health systems actually function. The quality on population health outcomes, which are very, very important, of course. Interesting one, role of consumers. We hear about role of consumers more and more and more in our health systems. So how do these other countries engage consumers in healthcare? And lastly, what's the evidence of system redesign and transformation that comes out of creating innovation and innovation initiatives in these countries? Very interesting when we looked at governance models. Essentially, we looked at every one of these 8 countries. And what was infinitely clear was there's essentially 3 models, broadly speaking, of health systems. And we've termed them differently. One is the state as guardian. France, Switzerland, Germany, and Netherlands, in fact, take a role as a government to be the guardian of the health system. but they don't actually implement and manage and direct and oversee operations of health system. They are based on a principle of solidarity, and essentially social insurance agencies administer health services, and they administer those services directly in collaboration and negotiation with health consumers. The state just makes sure that every citizen in the country has access to that fundamental package of health services deemed necessary in that particular culture. What's particularly interesting in that service delivery model, though, is the role of the consumer, who decides which of the social insurance agencies they're going to purchase or engage to deliver their health systems. And as soon as you have consumers deciding who delivers health care for them and how, then you have a very interesting dynamic of competition that sets up in those health systems that may actually play a fundamental role around their ability to create innovation. The second large group or type of health system models that we found was what we're calling the state as owner and operator of those health systems. And certainly this is where Canada fits quite well, Australia and the UK. And essentially these are based on principles of universality and access, and the state actually is almost the CEO of those health systems. They create the models, they identify who has what funding allocations for what service delivery outcomes, and even systems of accountability. What's interesting in the state as owner-operator, it is much more of what I'd say a hierarchical model of health systems, and consumers tend to more often than not be the recipient of the care. So typically when you go and you need some kind of support in a health service, you go into a physician's office or a community health center and you're given a set of instructions. Eat healthy, exercise. I know we all follow that in this room. Do all those right things to maintain our health and wellness. But it's tending to be more hierarchical. It doesn't engage a lot of consumer choice and decision making. It is the nature of the culture of those kinds of health systems. Of course, the third one is the US model, which is not either of the other two. It is heavily reliant on private insurance type of systems. It does have some publicly funded strategies like Medicare, Medicaid, the Veterans Administration group, who deliver health services that are publicly funded to particular groups. They have very high technology, phenomenal specialist care. They've been described often as over-providing care. Part of that may be related to their liability and the issues around health outcomes. But one of the interesting areas in the US is they have high numbers of uninsured. So in some cases, almost 40 million Americans don't have insurance. That's actually larger than some of the populations of the countries in this analysis. So that's the one challenge, or most substantive challenge in that country. And of course, it's also an issue of scale. It's a very large population. So delivering health within these private mixed models is clearly a challenge. So what are the key things we learned from that analysis? One is the control over public and private service delivery. National healthcare systems are the CEOs. They control, they direct, they oversee operations, essentially. Social insurance models, not so much. They're much more the guardians, and health insurance services are actually operated by individual agencies and insurance-based agencies. And what comes out of that culture of the two types of health systems is the important role of the consumer. Again, patients as recipients of care versus consumers as active decision makers. So within that context and that analysis of the cultures within which those health systems operate, we then went to all the published literature on what kinds of innovations are going on in those countries and what evidence is there that those innovations are actually leading them towards transformative changes in these systems. We used a qualitative analysis approach where we looked right across those countries to come out with the key strategies and the key lessons learned to create the dialogue in Canada. And I'll share with you somewhat a very quick global around the world tour of some of the innovation, and you'll start to see the patterns across these various countries that in Canada we might need to pay attention to. So innovation in the Netherlands. Netherlands is a very interesting country. It went through a very large health system redesign in 2006, and one of their very innovative outcomes was the Dutch personal health budget. And that's a strategy where consumers directly negotiate and purchase health services with those social insurance agencies, and those consumers are absolutely fundamentally responsible for coordinating and managing all their health care. Now, envision that as a family member. That means you would go to the agency, select the services your particular family needs to meet their individualized health and wellness needs. Very interesting in terms of the way they've been able to position that consumer and in some ways drive competition in the health system marketplace. The second thing that they did we thought was very interesting was creating after-hours primary care physician cooperatives. What that means is general practitioners in communities hold 100% of the responsibility for health service needs of the population 24 hours a day, 7 days a week. They adhere to very well-established quality standards that are set out based on best evidence by the state. Again, that state as guardian kind of model. They have had phenomenal, impressive results, and that's one of the reasons their wait times are so low. 90% of patients in that country are seen within 1 hour. If it's an urgent need for a health service, 70% of those calls are seen within 15 minutes. If a person in a community needs acute care, highly specialized care, for example, like an acute myocardial infarct, the GP has actually chauffeured cars, fully equipped with emergency medical equipment, gets them right to the hospital where they need to. What's fundamental in that is they also have only about a 60% hospital bed occupancy rate. So there's no real statistical measure where you can say that those two innovations in the Netherlands lead to no wait times in the Netherlands and a very low hospital bed occupancy rate, but it certainly makes you wonder if those two aren't tightly related to each other. Take a quick tour through France. France has a very similar 24/7 accountability strategy in place they call SOS Médecin. It's one of the oldest. It's again a network of on-call physicians. Annually, they answer 4 million calls and they make 2.5 million home visits. Those patients never need to go to a emergency department or a walk-in clinic. They simply don't exist because these patients are managed in the community. Now, patients pay for a visit every time they call SOS Médecin, but they're reimbursed by their social insurance company, so it's of no cost to them, and the access becomes 100% accessible. The other thing France has done is chronic illness management, and they've essentially created mandatory programs of chronic illness care plans, again, based on best evidence, overseen by the national government, but not implemented by the national government. General practitioners are actually incentivized and reimbursed to coordinate the care around those care plans, but consumers are also reimbursed indirectly because there's no copayment attached to any of the access to those chronic illness management programs. So in some ways, they've created financial models that will incentivize both provider, physicians, and consumers to manage chronic illness much more aggressively, effectively in their communities. Germany. You're starting to see the pattern similarly. Very well-developed chronic illness management program they call DMP's Disease Management Program, where they have extremely well-developed, again, coordinated care based on the major chronic illnesses apparent in that population. It's based on best evidence. Again, those primary care physicians coordinate that care. They're reimbursed and incentivized to do so. And this is another country where there is no co-payments. They're incentivizing consumers to make sure they're accessing and taking advantage of chronic illness management to maximize their health and wellness, again in communities, and much less need to rely on emergency rooms as it's more typically the case in Canada for primary care after hours. The second innovation we thought was particularly interested in Germany was something called a smart car. And although they've had not a smart car, I should say smart card. Consumers carry their own personal health records almost on like a Visa credit card. They decide who they're going to share their personal health records with simply by swiping their card and then entering a PIN to manage privacy. Consumers have had a somewhat mixed outcome in terms of adopting those smart cards, but it's slowly having the uptake they hope to. There's no evidence that suggests that that's actually transforming some of the productivity in their health center, but it's a very interesting innovation in terms of, again, giving consumers the tools to manage their health, but also managing the health records to do so. Switzerland. Now, a moment ago I said Switzerland was notable because Switzerland's a country where their citizens think it's the most wonderful healthcare system in the world. A third of that healthcare is paid for out of pocket by those citizens, a third by social insurance, and then a third by the state. Not a great deal of evidence in the literature around innovation initiatives in Switzerland, but two that really stood out among the other countries. One is what they're calling a physician-pharmacist quality initiative. And what they've done is create relationships in networks of physicians and pharmacists to look at prescription patterns, medication reconciliation, and outcomes of prescriptions to achieve the best outcomes for patients using the most cost-effective evidence-based strategy. On the few studies that have been able to capture the outcomes of this pharmacy quality initiative, drug costs per patient were cut in half for the patients that actually participated in that program. They relied on much heavier use of generic drugs, and the importance of best practice prescribing was identified as one of the critical attributes of the success of that program. The second thing Switzerland's doing, which I think is something to really think about carefully as well for Canadians, and that is creating a health literacy initiative. It's fine to say consumers should make all the decisions and consumers should be negotiating services and all those things. Consumers need the tools to do that, and Switzerland has gone down that road of working with patients and families and consumers around what is the best use of health services, how do we reduce unnecessary consumption. That's like going to the clinic every time there's a sore throat. Is there a better way to walk through some decision making with patients and families before they make the decision to actually access health care? They've developed one of the first health literacy surveys we can find in the world. It's certainly the only one currently in Europe, and that may be a very important initiative going forward as we look at how we engage consumers more dramatically. Innovation in the UK. There was no question UK has the most published literature and really substantive evidence, although it's not necessarily strong. It's certainly in the pilot phase around the outcomes of innovation for that system. They're actually going through a phenomenal transformation of the entire system, and this really just captures a few interesting things they're doing. One of them is called the Unique Care Program, and that's where they have put together a program that integrates both the health and the social service needs for high-risk populations, just one of whom is the frail elderly. The UK has a much older population than Canada, and it really deals with that fragmentation issue where a family with an elderly family member has to get one resource from social services, another one from health, and then trying to coordinate and make them all work. They've had phenomenal uptake of this Unique Care Program. Not strong evidence, but the program itself is actually quite new, so we look forward to watching to see the degree to which coordinating care by integrating health and social services actually avoids hospitalizations and repeated hospitalizations for those high-risk populations. Virtual hospital is almost another version of the same, where people who need care but don't need to be in a hospital to receive the care actually receive it in a community ward environment. They call them matrons. The head nurse of the service has a whole team of multidisciplinary providers around her, and they make sure the care and the surveillance and the monitoring of these frail and high-risk, again, population is all managed at home in the comforts of their own communities with their support systems around them. And again, that's driven primarily to decrease the reliance on hospitalization. The third one that's quite different from some of the other countries is what they call GP commissioning. And that is they've zeroed in on the primary healthcare physician who become the hub coordinating and commissioning, meaning deciding what specialist services, whether it's diagnostic imaging, rehabilitation, or any of those other needs, are needed for a particular family and loved one, and then they organize and oversee and coordinate that service delivery to make sure the care is appropriate and based on high quality standards. GPs in this GP commissioning model are actually incentivized not by volume, not by how much coordination they do, but the degree to which they achieve population health outcomes. So when they have healthier outcomes among the families they're working with, that's how the financial models are reimbursing this group of physicians. Australia, moving to our south of the equator. Similarly, you'll start to see again what some of these trends are across these countries. Australia has created what they're calling general practice networks. Similar to other countries we've heard about, 111 physician networks are in place in Australia, which involve 90% of their primary care physicians. They are funded and incentivized to provide and hold responsibility, again, 24 hours a day, 7 days a week, accessing the health services they need. Their focus is very much on improving coordination, early intervention, and prevention, to keep people out of hospital again and minimize the use of much more expensive health services resources, and a particular focus on chronic disease management. Second thing Australia has done is use telehealth to achieve the access across those very large geographic settings. That's improving access to rural communities. In Australia, you can be in any small town, use telehealth to access that specialist care you need wherever that specialist happens to be practicing. They've also got a very long and strong initiative is how do you attract physicians to practice in rural settings or remote settings. They create and set up the entire practice environment for physicians, so they remove all those back office kinds of challenges, and then they allow those physicians to support population health outcomes in their practices and incentivize them accordingly. Last but not least is the innovation in the US and what we can look to and learn from. The American system is really focused on two things. One is integrating health services, and generally there were several examples of these, primarily focused around particularly large acute care health systems that reach out into their community partners and create almost a hub and spoke model where the general practitioners in the community are linked to the specialists, and they can look across the continuum of care to make sure families are receiving the health services they need. They provide a great deal of community support services that are attached to these integrated programs, and they rely very heavily on technology, as one might expect. They use e-prescribing, electronic medical records, remote monitoring to make sure families are connected to their health providers very directly to oversee their care. Second thing the Americans' evidence in the US and innovation is around chronic illness management. These are not as well developed as in other countries, but there is evidence that that's a trend they're starting to look to, and in fact a couple of the manuscripts we looked at, they're really looking to the Netherlands model to see how it might work in the US system, and they are conducting pilot projects around diabetes management using, again, technology from remote monitoring and trending, and they're finding that when consumers know their health providers are well aware of what's happening with blood sugars over time and use of insulin, then those consumers are far more likely to comply and remain on that prescribed treatment protocol. In Canada, what did we find? We found some innovation, but I have to be honest, we had to look a little harder. There is very clear evidence in 3 provinces anyway, and there may be more, it's just not all of it's published or we didn't find it. Ontario and Quebec have really looked towards strengthening primary care using a team approach to primary care. In Ontario, of course, that would be our family health teams. Alberta has looked towards really zeroing in on consumers in managing chronic illness, and in fact, we found a study in Calgary that realized a 34% reduction in emergency department visits in 1 year for those patients engaged in that chronic illness initiative. The other thing Canada is well known for around the world is the Ontario Telehealth Network. It's the largest telehealth network in the world, extremely well developed, and what they're looking for in terms of moving forward in the use of telehealth in managing healthcare is to extend a connection between people in their homes and their healthcare providers to create that connection again between the consumer and their healthcare provider. So the key trends that jumped out for us in this analysis was no question the majority of innovation is shifted its attention from acute care, very well organized, comprehensive models of community care, many of which are focused on chronic illness management and or, which is often one of the same, frail or high-risk populations. Second, unquestionably, almost every country in the world, except for Canada and the US, 24/7 accountability for health services in the community, not using emergency departments as that default center for primary care when a doctor's office closes. Third, no question they're creating financial models and incentives that don't just fund physicians to engage in this kind of innovation strategy, but it's even incentivizing consumers. So that's an interesting opportunity. How might that look in Canada? And lastly, consumers are very, very actively engaged in managing their own health and wellness in the context of this transformational shift into community-based care models of healthcare, and we have not seen evidence of that to this degree, certainly in Canada to date. So how does that lead to our recommendations? Well, I think there won't be too much and too many surprises on these recommendations. We're suggesting as our first suggestion that Canada really needs to rethink and create a new consumer-driven culture of Canada's healthcare system. Now, I would caution, I am not suggesting we look at one of these other countries, simply drop that model of health system into Canada and expect all our ills and problems and challenges to go away. What I'm really suggesting here is rethink how we deliver healthcare services, look at how we engage consumers, how do we accomplish consumer choice within the mandate we have around the Canada Health Act, how do we empower consumer decision making, and how might that drive competition among health service organizations to achieve an innovation mandate. Can't do that unless we educate health professionals more in terms of their role as expert coaches and mentors. Not the all-powerful experts that tell you what to do, when to do it, and how to do it, and it's your decision if you decide to follow it, but they become partners in community health care and health and wellness. And thirdly, we've got to give consumers those tools and improve health literacy so that they can actually make very good decisions about managing health and wellness based on best evidence, not simply the wing and the prayer approach when you make those kinds of changes happen. Second recommendation, shouldn't be too big of a surprise, is really transforming our health system into a community-based care system focused on managing chronic illness, prevention, health, and wellness. What are some of the three things we're suggesting that would help us achieve that? Consider creating that 24/7 accountability among healthcare providers in our communities. Move away from that tendency to just all show up in emergency at 7 o'clock on a Friday night when we might need help. Create new models of chronic illness management, much more focused on achieving those quality outcomes, best evidence, population health outcomes, rather than show up at classes and do all the things we sometimes do just to teach people, but then we don't follow through. And third thing, develop financial models that will incentivize outcomes around population health. So we need to maybe think about how do you create those financial models so that the innovation and transformation will happen and we're rewarding the right kinds of outcomes. And in our comparator countries, I would suggest those outcomes are all around population health outcomes based on best evidence and not simply fee-for-service models that are driven by volumes. And the third recommendation, and this is where I think Canada could actually play a substantive role. When I looked across all 8 of these countries, what was really shocking as a research lens is we have relatively limited evidence, empirical evidence, like research evidence that says, here's how health system innovation happens, here are the facilitators, here are the key drivers. So what I'm suggesting is Canada maybe lead globally around creating the evidence and create a national strategy for health system innovation based on best evidence. Coordinated proof of concept testing. We need line items in our budgets that are identified as innovation money to develop those proof of concepts, collect that empirical data so that we begin to learn over time and build those innovation opportunities into the fabric of our healthcare systems. In order to do that, you have to create metrics and measures to capture impact. We can't just focus on, does it improve health outcomes for an individual patient by 5 days, 5 months, 5 years? What's the system level impact and what opportunity is there to transform how we deliver healthcare in new, more productive, more cost-effective ways ways based on best evidence and using an empirical approach. And finally, create the evidence for the impact on quality standards so that we standardize quality no matter where you live, what small community, what large urban center, you can expect and access high quality, best evidence healthcare that is actually sustainable going forward in terms of cost benefit outcomes. So to conclude, I think these global comparisons provide a very rich platform for dialogue and innovation in Canada. We need to think about it within the rich culture of Canadian citizens. They value our healthcare system very, very dearly. So we need to think about how do we create that transformational shift into empowering our Canadian consumers to manage their health and wellness. How do we give them the tools? How do we embed innovation into the fabric of our healthcare systems and agencies so that we are all working together to achieve that transformational shift and realize the gains in both in population health outcomes, but also quality of life for Canadians. Thank you.